Once again, good afternoon to all. So today, this topic, as a medical professional or as like a nurses, I know this topic is not a new topic, but it is very very important, basically in palliative care. That's why we going to discuss. So initially, I'm going to directly before going to the topic. Today we have a no case discussion. So through one case scenario, we can enter into the topic. So this case scenario, according to my experience,
There is a technical glitch. Please wait for a minute.
Hope the screen is visible to everyone. Somebody please confirm. Is it visible?
okay, sorry for delay. So through one case scenario, we can enter into the topic. So my patient, she's a female patient, 45 years old, diagnosed with CA colon with bone metastasis. So now her present complaints are having abdominal pain, having rectal discharge with along with the rectovaginal fistula is the reason. Then abdominal distension she have. Then we ruled out ascites. Then oral intake very much reduced due to the vomiting and nausea and insomnia also. Then psychosocial aspect of this patient, she is living with her husband and two children, one boy and a girl child. Both are studying. Boy elder on in 12th standard and younger girl is studying in 10th standard. She coming from a poor socio-economic background. Her husband is the breadwinner of the family, but now he is unable to go for work due to the disease condition of his wife. So according to her spiritual aspect, she's thinking, why did God punish me like this? Then her wish is to go back to home from the hospital and die in her bed. Then she very much like to wish her priest. Current medication she getting for pain, we started tabumorphine 10 mg fourth hourly is continuing. Along with that, as a laxative tab, bisacodyl 5 mg 2HS she getting. And tab metoclopramide also 10 mg TAD we regularize for the vomiting management. So her main concerns, first one abdominal pain, along with that this vomiting and insomnia and the financial crisis about the family. So our discussion point, how can we give pain relief when the oral and intravenous routes are inappropriate for this patient? Second one, can we able to fulfill her last wish, which was die at home? So from this discussion point, we starting our topic.
So what do you think? This patient is on morphine 10 milligram 4 hourly, bisacodyl 5 milligram 2HS, and tab metoclopramide 10 milligram TAD. So because of her vomiting, she is not able to take oral tablets. So at the same time, she is having pain, severe abdominal pain. So we need to relieve her pain. So what all the oral the route is not possible. And also she underwent multiple the cycles of chemotherapy. So now we are not able to get her intravenous line also. So we need to give a multiple tricks, but at the same time we are not able to get the intravenous route. So that is the scenario. So this patient is not able to take medication through orally, and the intravenous route is also not possible. So what is the other option? Please suggest, please unmute yourself and talk, or you can put your answers in the chat box. So these are the two points. The first discussion points, we have to give a pain relief, no? So what are other routes? And the second thing is, she wants to die at home. Can we allow her to die at home? That is the second question. Subcutaneous, Dutchan said subcutaneous. Intramuscular injection, okay. Okay. Intramuscular injection. So how much you can give through intramuscular? She need continuous infusion. How will you give intramuscular injection? So how will you give this much of amount through intramuscularly? So that is the another thing. Anyway, Dutchan said a subcutaneous route. That is correct. Yeah, yes, we have syringe driver. Dutchan is asking, do we use syringe driver in India? Yes, we have syringe drivers. We used to use the continuous infusion through syringe drivers. Okay. Thank you. Thank you for your answers. Thank you.
So Today we're going to discuss about the subcutaneous route. Through this route, we can give the bolus injections and the infusions too. So this picture you can see according to the route of administration as a parental route of administration of medication. We mainly choosing intravenous route, along with that intramuscular route. But subcutaneous and intradermal little bit comparatively is less priority in general setting. But in palliative care, our main priority goes to the subcutaneous route for injection and the infusion. Here you can see one on angle for pricking the sites. Intramuscular means 90 degrees, subcutaneous means 45 degree. So actually for the subcutaneous injection, we mainly preferring 30 to 45 degree of angle. That basis, we need to prick the area with the needle. So actually, what is subcutaneous tissue? Can anyone suggest? Actually, the subcutaneous tissue consists of what? Fats. Okay, thank you for your response. Actually, subcutaneous tissue, it's true. It consists of fats and collagen fibers. So in this picture, you can see the subcutaneous tissue, that yellowish layer, hypodermis subcutaneous tissue. This tissue consists of fats and collagen fibers. Underlying some small capillaries also there. So first of all, we can just introduce about the subcutaneous. This subcutaneous route, when we injecting some medicines or we introducing some infusion to the subcutaneous space or subcutaneous tissue means it will collect over there and gradually it absorb from the tissue. So directly it will not enter into the capillaries or to the bloodstream because it's containing fat and collagen fibers. Indirectly, it inhibiting the direct absorption to the bloodstream. So we can move to the topic. Subcutaneous infusion, or it's have another term also, hypodermoclysis. So from the term hypodermoclysis, we will get the meaning. Just split the word into three. Hypodermoclysis. Hypo means below. Dermo means dermis layer. Below the dermis layer, in picture you already seen subcutaneous tissue. Clysis means administration. So subcutaneous infusion and the hypodermoclysis both are same, but is having little bit differences there. Hypodermoclysis means if suppose we giving a large volume of as like infusion or large volume of medications to the tissue is called hypodermoclysis for the rehydration purpose. Mild to moderate dehydrated cases, if suppose we giving anything for the rehydration purpose, we can call it as a hypodermoclysis. It's as like infusion in small volume or maybe the large volume. Small volume means as like bolus injections. Large volume like for the rehydration purpose, something as like infusion, as like drip we putting means it's a large volume. So main indications are already told, mild to moderate dehydrated cases. If we have any plan to rehydrate means by subcutaneously we can give fluid for the rehydration purpose. But severe dehydration means we cannot choose the subcutaneous route because tissue absorption is very poor. So in that time we need to select intravenous route. We need to correct it. Then we can come to the subcutaneous route. Second one, severe dysphagia or swallowing difficulty. Already if existing the patient having the complaint of swallowing difficulty or any dysphagia already complaint means for that patient oral route of medicines we cannot suggest to continue. So by subcutaneously we can manage. Then if we have a plan to give maximum 3 liter or 6 pint of fluid within 1 day or within 24 hours, we have one plan to give us like infusion means we can put by subcutaneously. So those indications are main indications, but in palliative care, these are all the some more and common indications. First one, nausea and vomiting. If the patient having severe nausea and vomiting due to the disease condition or maybe due to the progression of disease, nausea and vomiting. Vomiters contain maybe something like fecal matter, like that profuse vomiting cases. Oral route of medicines, they cannot continue for the symptom management, or oral food patient cannot take. That condition, by subcutaneously for rehydration or for the symptom management, we can give the injections and the infusions. Then already if the patient having esophageal lesion or mouth or throat area, any ulcer formation already is there, burning sensation is there, according to that swallowing difficulty already is there. That condition also by subcutaneously we can manage the symptom. Then obstruction, majority of the gastrointestinal cancerous condition may be due to the primary diagnosis basis or according to the progression of disease. At any time, this intestinal obstruction we can expect. So if once the intestinal obstruction is happened, means we cannot continue anything by orally. So, but we need to manage the symptoms also. So for the symptom management and for maintaining the quality of the patient, if we needed to rehydrate or needed to give any medicine, means by subcutaneously we can give. Another on unconscious patient. I am not telling about the unconscious patient. Generally, you are seeing in the ICU setting. Here I am mentioning about the unconscious patient is in end of life stage or terminally ill stage. Condition of the patient is deteriorating, going to ill. In that condition also, some minimal medicine suppose needed to manage the symptoms, which are all the symptoms he have. That minimal medicines already need to continue, or for the maintaining the quality of the life of the patient till his or her death, something we need to give as like fluid. That purpose in that unconscious condition also we can give something by subcutaneously. Then if one patient you are all seeing with severe pain means pain score you can tell it as like 9 by 10 or 10 by 10, that much severe pain cases. If suppose that patient already taking tab form of medicines for the pain management, or maybe if suppose we needed to start anything for the pain management at that situation. So in this much severe pain, patient was crying due to the pain. That situation, if suppose we planning to again to give taboo form of medicines for that pain management, means in that situation it will be inappropriate. So that condition we can give something for the pain management by subcutaneously. Then we can switch to the taboo. Then if one patient is already existing, example tabomorphin for the pain management forthwardly by orally, already existing frequent doses is there. But due to some symptom basis, means example due to the vomiting or maybe patient itself refusing to take anything by orally, that condition, and another route we can prefer rectal route. Same dose of morphine in paste-like form we can apply in the rectal route. But in some condition, this rectal route also it will become inappropriate. Example, see a rectum case or already existing hemorrhage or any spurious diarrhea. Anything is there means we cannot prefer rectal route for the administration of medication. So in that period, we need to maintain the symptom by subcutaneously. We can give the medicines. Then we can move to again, if it possible means we can move to the tablet form. So next on sites. Sites means which are all the areas we can give subcutaneous injection or infusion. Anyone can answer? In your practice, from your practice, you can tell. Okay, abdomen, thighs, abdomen, abdomen. Thighs. Okay. Okay. Thank you for your responses. So these are all the areas we can give the subcutaneous injection or the infusion. First one, upper chest or intercostal plane. So this picture you can see the red dotted areas are already mentioned here, upper chest or intercostal plane. So if we choosing this area for giving subcutaneous injection or infusion, suppose for the female patient means be very cautious, don't involve with the breast tissues because it will damage the breast tissues. Then another one, upper arm or outer aspect or lateral aspect of upper arm. Then abdomen. Abdomen actually we telling 2 inches away from the belly button around the umbilical region on the abdomen, we can give the subcutaneous injection or infusion. Then outer thigh or lateral aspect of thigh. Then upper back or outer quadrant of the buttocks, upper back. Then scapular region. These are all the regions we can give the subcutaneous injections or the infusion. But in our setting also, we mainly preferring the upper arm and the outer thigh. Why? Because in our setting, we mainly doing these things for the benefit of the patient, making them to independently manage in their own home, if it possible. So in that condition, our main goal will become caregiver education. As a part of the caregiver education, this subcutaneous injection and the infusion method, we can educate to the caregiver. So this upper arm and outer thigh is more confident to them to give this injection or infusion. That's why only we most of all preferring upper arm and outer thigh. If suppose any contraindication is there with this area, means we will choose other areas, upper chest or abdomen and upper back, scapular, other region also we can choose. So these are all the areas we cannot give the subcutaneous injection or infusion. First one, already existing the lymphedema, already the one limb affected with the lymphedema, that limb we cannot choose for the subcutaneous injection. Then recently irradiated skin, any skin inflammation or infection sign already existing tumor and scar tissue area. These are all the areas we cannot give. Then if suppose we choosing the abdomen means also already existing ascites, means we cannot give the injection in abdominal area. Then not only the lymphedema, pitting edema also. If already having the pitting edema means also we cannot give the injection or infusion in supposed to that area. Then bony prominence near to the joint area, already the skin folds, mainly obvious patient means the skin folds, maybe it will mislead to the subcutaneous tissue. While we pricking means also maybe it will not be in the subcutaneous tissue area. So these are all the sites we cannot give the subcutaneous injection or the infusion. So about the medications, can anyone suggest some of the medications we can give by subcutaneously? From your experience. Mainly giving by subcutaneous medications. Insulin, okay. Insulin, heparin, okay. Morphine, midazolam, okay. 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 Thank you for your responses. So these are all the some of the common medicines in our setting. Also, we practicing to give by subcutaneously. So, but studies are going on. Some more drugs are already proved and proving by subcutaneously we can give. But these are all the some of the example medications: injection morphine, haloperidol, midazolam, metoclopramide, or perinom, hyoscine butyl bromide, or buscopan, fentanyl, tramadol, Emised, glycopyrrolate. So, as a bolus injection form, these are all the common medicines we can give by subcutaneously. As like infusion or as like a fluid administration, mainly we telling normal saline, sodium chloride containing, means 0.45% to 9.9% sodium chloride containing solutions. Means normally normal saline we can put by subcutaneously, but along with that we theoretically telling it is possible dextrose normal saline and the ringer lactate also. So these fluids we can give by subcutaneously, but in my practice also I practice only the normal saline as like infusion by subcutaneously. So these are all the medicines we cannot give by subcutaneously. So injections, diazepam, chlorpromazine, and the majority of the antibiotics, but some minimal antibiotics as in diluted form we can give by subcutaneously by didn't. But majority of the antibiotics, antifungal medications, highly concentrated medicines, hypertonic solutions as like 3% NS type hypertonic solutions. So these are all the things we cannot give by subcutaneously, because already I told directly it's not at all involving with the bloodstream. It's a space, it's collect over there, from there it's gradually absorbing. So highly concentrated medicines and hypertonic solutions cannot absorb by the tissues. So it will cause the tissue damage on the area. So the part of the procedure, first of all, whenever the patient is reaching to us, when we starting the subcutaneous infusion or injection, we need to explain about the procedure to the patient and the caregiver, because actually subcutaneous route of administration totally a new one for the patient and the family. So we need to explain about the things. Then hand washing is important. Then assemble, set everything, fluid and tubings and prime line, selected tubing, selected fluid according to the doctor's prescription. We need to set everything. Then whichever the area we already selected to give this subcutaneous injection or infusion, that area after the selection we need to clean the area with antiseptic solution, soak the swab by using circular motion from the center to the outward direction. We need to clean the area, leave for few seconds for drying. During the drying period, again don't touch with our fingers already cleaned area. Then insert the needle. Mainly we using for infusion purpose, we mainly using the SV set or scan vein set. Butterfly cannula we mainly using. So whichever the needle we using for pricking the area, 30 to 45-degree angle we need to prick on the tissue. Then after pricking, after inserting the whole needle to the tissue, secure the wings of the SV set with the help of the occlusive dressing. Then according to the doctor's order, we need to adjust the fluid drip rate also as per the prescription. So now we can just see the video about the procedure, then we can come back to the topic. Okay, everyone seen the video. Have any doubt on this video about the procedure? Okay. In this video, we mentioned we need to put the date and the time. So my question, up to how many days or how many, means how long we can maintain on subcutaneous area?
The question is how often we need to change the subcutaneous site. Anybody have any idea? So Purva said after 72 hours. Any other opinions? No. Every time. Okay. Angela said every time we need to change the site. Every time means after every infusion, do you mean? Okay. Thank you.
Okay, thank you for your response. So ideally we telling by theoretically 5 to 7 days we can means 5 to 7 days often we need to change the site. So before that we need to assess something. So in coming slide we will discuss about all those things. Next. So before that, we can already I told in second slide, maximum 3 liter or 6 pint of fluid already we have a plan to give for the patient means by subcutaneously we can give. So it's how it possible. Maybe that thought will be coming into you. So here we have oleum and rate. First one, if suppose we giving bolus injection for a patient means 1 ml per minute rate we need to maintain. Suppose more than 1 ml quantity of medicine we have means 2 ml or 3 ml quantity medicine means 2 minute or 3 minute we need to take for injecting. Then as like infusion or as like drip we putting means 20 drops per minute is the maximum. So 1 ml per minute or 20 drops per minute is the maximum rate and volume we need to maintain. Then it will be comfortable. If suppose it's crossing means it will cause the pain and burning sensation on that area for the patient. Then coming to the some more deep explanation about the 3 liter. In one side we putting means maximum within 24 or within 1 day. In one side we can give 1.5 liter or 3 pint of fluid. Again one more side we can choose again 1.5. So in total 2 sides total 3 liter or 6 pint of fluid we can give by subcutaneously within 24 hours or within 1 day. This is the maximum. One more site it's not at all possible. So this also again I am repeating, theoretically we telling 3 liter is possible, but practically in palliative care setting maybe it's not at all needed for maintaining the quality of the patient, for the maintenance of the hydration level of the body. Only needed some infusions as like for the rehydration. So maybe this much quantity not at all needed, but it's possible. So already explained about the procedure. Now after the procedure, we need to document the everything about the medicine rate and volume. Everything we need to chart in the medication chart. Then even after or soon after starting the infusion or just giving the injection, after 1 hour we need to check the site, ensure that there is no leakage or any edema. A mild edema is normal only. That thing we need to, before the procedure, we need to explain to the patient because it's a space while we injecting, the thing is collected over there and gradually absorbing. So a mild edema is normal only. So after some time, it will gradually subside. That thing we need to convey to the patient and the caregiver. But in some cases, the edema, it will not subside and it may will become increasing. Or it last leads to the leakage also. These are all the things we need to just assess soon after starting the infusion after 1 hour. Then if necessary, if it needed means after the infusion, this edematous site, we can give a gentle mild massage we can give for subsiding. Then again, it's not at all subsiding and increasing means we need to change the site. So we can move to the about the advantages also. These are also some of the main advantages because already I told in palliative care setting we most of all preferring the subcutaneous route. That's the reason these are all the advantages. First one, it's a low cost. I already told, most of all for giving infusion or continuous infusion, we choosing as like a cannula, we choosing the SV set or scalpel set. It's very much cheaper than the IV cannula. You all can think about the one IV cannula rate. According to the hospital setting, the rate it will vary, but minimum 95 rupees onwards, 95, 105, 150, like that the rate will come for the IV cannula. But here this SV set, its cost is only 18 rupees, 18. So that's the first priority reason. It's coming under the advantage. It's a low cost, then more comfortable than the IV administration. So if during the procedure, just think about the processing for the IV cannulation. What are all the painful process and painful steps we will do, and at last we will succeed for the IV cannulation. But suppose due to any reason this cannula is blocked, or maybe the IV line is coming out, means again same painful process need to repeat and repeat for doing on IV cannulation. So in the subcutaneous route of administration, there is no this much painful process and further procedure not at all needed. It's a simple procedure. It's more comfortable for the patient and the staff also. So if suppose minimal staff is there, you can imagine only one nurse is there in front of the patient. Or maybe suppose you doing the home care in home setting, patient and from the team side, you only one nurse. Suppose you having that much not at all experience in the IV cannulation. There is no supervision is there, no helping hand with you. That situation, if suppose needed to put an IV cannula, means it will not possible, maybe. But in subcu, there is no supervision needed, no help is needed. Only we need to choose the area, clean with a proper antiseptic manner. Then we can prick by the 30 to 45 degree of angle by the needle to the area. It's a very simple process. Then the complications as like fluid overload, thrombophlebitis, systemic infection causing by septicemia, mainly happening in the IV route, it not at all getting chance for in the subcutaneous route, because it's not at all directly involving with the circulatory system. So if suppose anything happen, means also on that area, mean only will affect. Systematically, nothing it will affect. Then at last, one main advantage, at any time we can give and we can stop. Means if suppose you put on IV cannula today morning, you given on bolus injection today morning, after maybe after 10 hours or maybe after 24 hours, only needed to give another injection. Suppose during the period, maybe due to the blood clot formation, the cannula will become blocked. We need to change and we need to put another one. Maybe it's needed. But here, if suppose in subcutaneous route, one bolus injection be given, after 2 days also, with the same subcu route itself, we can give another bolus injection. Because here is no circulatory system involvement directly, no clot formation. So nothing, it will block the channel. So in that space, at any time, we can give the injection and we can stop the injection. So as like advantages, some minimal disadvantages is existing. First one, possibility for the irritation or the inflammation at the infusion site. One possibility is there. But in proper manner, we doing the process, means it will not cause, but it's a chance is there. Then possibility for the leakage. For every person, every subcutaneous tissue is not at all same. Maybe the absorption may be poor for some patient or poor for some areas of the subcutaneous tissues. So there will become one possibility for the leakage. Then allergic reaction. In some conditions, it's a very rare, but there is a chance is there. Allergy reaction due to the adhesive dressing or maybe due to the inserted needle on that area. It's a very rare, but these are all the some of the disadvantages. So these are all the some of the side effects, or we can call it as a complication, but some solutions also is there for some reasons. First one, localized edema. I already told a mild edema is normal only on that area, because it's a space, it's collect over there and gradually absorbing. So this mild edema we can manage with a mild gentle massage we can give on that area. Usually it will subside. Suppose it's not at all subsiding, the edema is increasing, means we cannot continue on that area. Then inflammation or cellulitis. Proper aseptic manner we following for doing the procedure means it will not cause for a cellulitis or inflammation. So very cautious during the procedure. Then pain and discomfort. If the patient is telling pain or burning sensation on that area, we need to check about the rate and the volume. I already told 1 ml per minute is the rate or 20 drops per minute is the volume. That rate and volume we need to maintain. Then it will not happen. Suppose they are complaining about the pain, means we need to check the rate and volume. We need to make it as a lower side. Then we can continue. Then puncturing of blood vessel during the insertion is not at all happen, but there is a chance is there over the period of keeping the needle inside the subcutaneous area, means after putting the subcu with the SV set, if the patient is capable, means they can move, they can do the jobs, self-care, everything they can take care with the site itself. So during the period, by walking time or accidentally any wall side or corner side of the door is hitting on that area, means already internally existing this needle tip may be prick underlying some blood capillaries. There is a chance for getting contact with the capillaries and bleeding will happen. Then it's evidently we can see it as like blood content or blood tinged fluid content inside the tube, accessory tube with the SV set. Suppose anything we see means we need to change the site. We cannot continue on that area. Then hematoma around the insertion site. This thing also happening mainly for the patient already receiving any anticoagulant therapy or lower side of the platelet level. That conditions or already taking NSAIDs. In that cases, this type of hematoma around the insertion site, it will happen. So we need to cautious about that. Then we need to move to the IV route for giving the injection. Then last one complication, we can tell it as like machine anything error or alarm sound is hearing in the machine. Mainly, I know you're all in your setting mainly for the continuous infusion, you're all giving the syringe pump or infusion pump you most of all using. In our setting, we most of all preferring the syringe drivers. So these are all the machines, maybe some occlusion, infusion device occlusion maybe happen. So we need to check about the tubing inside, any air bubble formation or any kingling in the external tubings, connected tubing, anything is there or not. We need to check, find out the reason and we can manage, then we can manage this reason also. So these are all the, as a nurse, these are the responsibilities for us. First one, soon after the starting infusion or injection, after 1 hour, we need to assess something. But after that, every 4th hourly, we need to check the site and we need to do these assessments. First one, any tenderness or hardness at the site is there or not. A mild edema is normal only, but it's very tender or very hard is there or not. We need to assess. Then any hematoma formation around the site is there or not. Then already inserted area, the edema is increasing and the leakage is there or not. Then any tissue irritation as like pain or burning sensation, patient is reporting or not. Then redness or erythema. Then presence of blood content or blood tinged fluid content in the external tubing of the SV set. Then displacement of the cannula. So these are all the things we need to check every 4th hourly. Suppose any displacement of the cannula is happening, means also we cannot continue on that area, just remove the needle. We need to select another site, reinsert, same procedure, we can continue. So in this nurse's responsibility, already I told these are all the things we need to assess every 4th hourly. Ideally, we telling 5 to 7 days we can keep on subcutaneous area for giving injection and the infusion. But in at any time, every 4th hourly assessment, these points at any point of time we noticing means we need to change the site. If suppose nothing is happening in assessment, everything is clear means only we can continue for 5 to 7 days on subcutaneous area for giving injection and the infusion.
Okay, thank you, Sajan, for the wonderful presentation. Anybody have any doubts? Anybody? So in this group, how many of you confident to give subcutaneous infusion? Nobody? So Dachan said, okay, she is able to. So I know this is a new route for you or most of you all because we all used to give intravenous injection and already you have mentioned the injections name through which we are giving through the subcutaneously injection heparin, erythropoietin, insulin and also. But what we have to understand is most of the drug which we are using in palliative care for symptom management can be able to given through subcutaneously. So that is why we prefer subcutaneous route. And also, if you take a subcutaneous route, we can avoid the multiple pricks. Okay, if you prick it on time, so the patient, nobody is willing to give your hand to others and ask them to put a cannula or needle in your hand. No, so we all are resistant. We all are hesitate to take an injection because we all nurses. Even then, we are not willing to take an injections. So we are worried about the pricks. Yeah, that the same thing, the patient side, you have to think about the patient sides instead of multiple pricks. If you choose a subcutaneous route, our idea is to symptom management. If you can able to control their symptoms, definitely we can able to improve the quality of life. So if you want to control their symptoms, if the patient is not able to take orally, maybe some kind of esophageal lesions or maybe CA esophagus, that kind of things, the oral route is inappropriate. And also, as Sajan said, you can give tablet through rectal route also. If they are not able to take it orally, you can given that the same dose through rectally also. Take a immediate release morphine and put the drops of water so that the pasty form you will get, and that pasted that morphine you can rub in the rectal mucosa. That will help to the patient to get pain relief. So again, the rectal route is also inappropriate. Then the option is intravenous. But the thing is, if you want to get an intravenous route, you have to give a multiple pricks. So that we can avoid if you choose a subcutaneous infusion, right? So always you have to think about it. If the doctor suggests subcutaneous infusion, please don't hesitate to give. As Sajan said, we can give 1 ml per minute. The 1 ml is 20 drops. 20 drops we can give through subcutaneously every 1 minute. No, so that is also very, very important. You have to keep it in mind. Okay. One question for how much duration or days can be large volume of infusion through subcutaneous route? So we can give that any days, because don't give we don't say like for 7 days, for 5 days. If the patient need, you can give continuous subcutaneous infusion. So we have patients like admitted in 10 days continuously, but if they need a continuous infusion, we will continue the 10 days. So that is depend upon the patient condition. If they have a dehydration, mild to moderate dehydration, there we'll give a continuous infusion through subcutaneously. We prefer normal saline, but sometimes we used to give dextrose normal saline also. Some of the places are giving ringer lactate too. So study says it will not create much problem. So these all that IV fluids are safe. But the thing is, we can that keep the subcutaneous route subcutaneous line for 5 to 7 days. But if there is any color change there, we have to we have to change the site. That is important. So as nurses, we have to check the site every 4 hourly. If there is any leakage or color change, there we have to change the site as soon as possible. And the another important thing, whenever the patients comes to you with the symptoms, or so they all have seen only the intravenous route, no? That time what we say usually, we all nurses saying like, if there is any swelling there, please report us as soon as possible. So that that is the intravenous infusion. When they come to palliative, if you choose subcutaneous infusion, that mild and moderate the mild edema is normal. So that is the new information. We have to educate the patient and family about that. Mild edema is normal in and around the site. That will absorb, that will reduce spontaneously, or you can give a mild massage. So that information you have to tell them. Otherwise, they will come to you as soon as after you start a subcutaneous infusion. That is normal. So that information you have to tell them. Okay, so we can move on to go back to the case presentation. There are 2 questions. Yeah.
So just we can come back to our discussion point already, the scenario I presented. First question was how we can give pain relief if the patient refusing or the oral and the intravenous route becoming inappropriate. Second question, can we able to fulfill her last wish? Her last wish was she need to die at home. So after completing this session, from your side, you can just give the point for the discussion and your idea for the management of these 2 reasons. This is the time you can put your points for the discussion about this 2 discussion points.
So the first question was, how can we given pain relief when the oral route and the intravenous route are inappropriate. So we already discussed that this patient is on morphine for pain management and metoclopramide for her vomiting, but she is not able to take it orally because of vomiting. So vomiting also we can control because she is not able to take the oral tablets. So the another option is rectal. Another option is rectal. We can give the primary main concern is pain management, right? So we can give rectal route, but the thing is, this here is a rectovaginal fistula. The rectal discharge is also there. We cannot give the rectal medication also. So here, oral route and the rectal route is not appropriate. So here we have to think about the another option. Then have to first in our mind come intravenous route, right? So there are another option, subcutaneous route. So if you choose subcutaneous route, we can avoid multiple breaks, definitely. As you suggest, Angela and Nasima suggest, subcutaneous route is the best way for her to relieve her symptom management. Okay, then the next question. Can be able to fulfill her last wish. She wants to die at home. Can you allow? This patient is admitted in your hospital. She is asking you, I want to go home. I know my disease. I know the prognosis of my disease. I want to go home and my wish is die at home. Please suggest.
Yes.
Yes. Angela said yes. Veena Nadar said yes. Then how will you send her? Because we need to control her symptom also. We need to provide a peaceful death to her also. So before sending her home, what all things you have to tell? With proper counseling, to whom? To the patient. Okay. Family. Educate the caregiver. About what? Nasima? Lipi Bishwas said we can go with the patient wish. Okay, definitely. We have to fulfill her wish. But before that, we have to do some that preparation things, no? Before sending her, we have to talk to the relatives, make them understand, educate the caregiver. So educate the caregiver about the infusion. So I think Sajan has more experience about that.
So our last and the second discussion point was, can we able to fulfill her last wish? So most of all, you responded as like positive manner. We can fulfill her need. Her need or her last wish was die at home. So in medication, already I told about the for the pain, already giving morphine. Fourthly, we giving the morphine. So according to the titration value, from the oral to the subcutaneous, we can convert as per the doctor's prescription. We can convert, and whichever the dose frequent dose for 4th hourly or 6th hourly according to the doctor's order, we can maintain the subcutaneous injection. In the hospital setting itself, we need to make the diluted dose for the frequent bolus injection. We need to give the injection in front of the caregiver. We not at all starting the procedure from the injection time. We will start the procedure from the pricking time itself. About the subcutaneous route of administration, a simple explanation we need to give to the patient. During the procedure, I already told about the procedure, we need to explain to the patient and the family. Same thing here we need to do. Or otherwise, they will compare this edema with the IV route edema. So that thing we need to convey first. Then the benefit of this injection and infusion, everything we need to explain. Then the procedure as like pricking, securing, and everything we need to demonstrate in front of them. If it needed means we can make them to do, if it possible means. Then the diluted medicine, this morphine, how much ml, that ml contain how much mg, everything in a micropore we can write it in very clearly, and we can stick on the syringe. Then we can clearly convey to the caregiver. Then frequently how much ml need to push, that thing we need to clear, make them to clear. And after the injecting some normal saline, we need to push after completing the injection and infusion. Why? The reason also we need to explain. External tubing, some medicine part will be there. We need to flush complete medicine to the subcutaneous tissue. So after giving every frequent injection, suppose injection means I am telling, in the bolus injection we giving means also, after that we will push some 0.5 ml at least normal saline we need to push after completing the bolus injection. That thing we need to convey to the patient caregiver, or otherwise half part of the prescribed medicine only will get to the tissue. Pain relief will not be adequate. So that thing we need to convey. Then what are all our responsibility? As like same, what are all their responsibility to assess on that area? What are all the things they need to assess? Anything they notice means how they need to change. Everything we need to convey to the patient. Then advantages also. Now her wish was die at home. Now she is getting some tab form of medicine. Frequently, every 4th hourly, patient need to wake, patient need to be sit, or otherwise elevate the head and need to give the frequent medication. Patient is distressing or may feel of disgusting due to this medication. Patient need to stop this type of oral medication. Already existing vomiting also. So injection only is possible, or injection only comfortably we can give to the patient, or otherwise in gradually patient will purposefully refuse every oral medication. Then symptom management will not be possible. Dying stage also very painful. So unknowingly she only may need to select a painful death. So that situation we need to stop that situation. So that importance we need to tell. And in home setting itself, in her wish, in same bed, whichever the bed already the patient was lying and sleeping, in the same bed itself, same room itself, according to her dream, according to her wish, she can be there according to their wish in same home, same bed, frequent this type of injections without just wakening up for the frequent oral medication. We can make her to get a nice death, a peaceful, pain-free death, distress-free death. So that's the main ideal thing happening in the palliative care. That's only the subcutaneous route. We most of all giving this much important, and we promoting this route for administering this type of parenteral route of administration.
Okay, thank you, Sajan. So as Sajan said, So we have many patients like this. The patients will be maybe their wish is to die at home. That time usually the relatives they are not willing to take them at home because they are reluctant to take her home because of the symptoms. So if there is any problem develop, how can they manage that? That kind of anxiety will be there inside the mind all the times. They will be they always say like no, we will not take it. So that is the usual response. What you can do is you have to sit with the caregivers first and listen their worries, and you have to tell them like this is her wish, we need to meet her wish. So what all things your worries, what all things inside your mind, please tell us, then only we can able to help you. So if they said like this, so we have a syringe driver. I don't know how many of you have seen syringe drivers. So syringe driver is like a syringe pump. It's smaller one. It's a portable machine that can able to take when if they are able to walk, they can take carry. So small portable machines. So what we do here is we load that medications into the syringe, and the put syringe driver things. We educate the caregivers about the syringe driver, that machines operating, that all things. And then we usually put a subcutaneous line and give a continuous infusion. So after that, they can able to manage. So the important thing is this needle is in the subcutaneous the site, right? Even if the needle is not fallen, so that accidentally come out, no worry about that, because no blood, that will be that needle is in the subcutaneous tissue, right? No blood coming out. No worry about that. So one thing you have to give a good confidence to the caregivers. Nothing worry about this. We will teach you everything, and then they can able to give injections if they need a bolus infusion. If the patient need a bolus infusion, we can teach them how to give a bolus injection. So we have seen many patients like this. After when they go back after 1 hour, maybe on the next day, the caregiver will were called us and tell like patient was died at home peacefully, that kind of. So how that time they felt like very happy because they need to they actually fulfill their her wish, no. So that they felt that always they remember that kind of things. Okay, so that time this subcutaneous infusion is very very important. Dachen, do you have any experience? I think
Yes.
yeah.
Yes. In the UK, we use McKinley T34 syringe drivers. And the needle that we use is the Intima one, which is, we don't have the metal needle in the patient's skin. It's usually just a very, very, very fine. Initially, when we insert the syringe driver, I mean the needle, there's a very fine needle. And after the needle is in place, we take off the needle and the, the inner, the plastic one that stays is very fine, such that the patient doesn't feel any pain. But if I'm not mistaken, on the demonstration video, is the metal needle in the patient's skin yet?
Yes, we are using the metal skin, the scalp vein set.
Oh, that looks painful, isn't it, actually?
So when we insert, it's little pain will be there, but after that, we don't get any that feedback from the patients till now. So after when we insert a needle, little pain is there, but after that they will not get any experience any pain.
Oh, is it because of the cost of the appliance, or is it because it's not available in India that we are not using the ones that are used abroad?
Yeah, that I don't know. So we used to give that cannula, IV cannula. Does that mean? Do you mean that IV cannula?
No, it's called the hypodermic set. It's a
Oh,
whole set.
we don't. So can you take a photo and send it to me?
Sure, I'll do that.
Yeah, so I want to see that. This,
And also,
ah,
can I request if you could show us a syringe driver to the class, because I think so many of us have not seen a syringe driver.
okay.
I have seen one in the UK, but I don't know what is used here in our country.
Yeah, here we are using 1 hour. 1 hour syringe driver and 24 hour also.
And if suppose the patient is on a pain medication, for instance, morphine, and in case, even as the infusion is going through and patient experiences pain, and we give an additional dose of morphine or something else for the pain, is the syringe driver, do you increase the load the next day, calculating the requirement of the patient?
Yes, we will calculate the bolus dose and we will increase the dose 30 to 50%. We will increase.
Yeah, that's what I've experienced actually. Thank you so much.
Okay, thank you. So maybe one of the next session I'll show that syringe driver picture. So syringe driver to you all.
Thank you.
Okay. Okay, if you don't have any questions, we can wind up. So one of you asking about the cold compress applications, because that is not necessary. So continuous infusion, it will not help much. If there is any, like as we discussed earlier, mild edema is normal, that will subside spontaneously. But if there is more edema there, we can give us that light massage. So that will help to reduce the edema. Okay, thank you. We can wind up the session. Thank you, Sajan, for the wonderful presentation. Today we don't get any case presentation. That's why we bring a patient story the first part. So anyway, thank you for your participation and your interactions. Thank you.